Welcome to the Resilient Training Lab podcast.
Hello, everybody. Welcome to another episode of the Resilient Training Lab podcast. I'm your host, Ryan, here with Coach Paul, as well as the newest member of the Resilient Training Lab team, Ryan VanNieuwenhuyze. So welcome, Ryan.
Thank you.
Yeah, you got it. So today we're going to talk about the spectrum of physical therapy and rehab all the way through strength and conditioning and performance. Ryan's going to talk to us about this. He's a doctor of physical therapy, and I'll let him tell us a little bit more about his background.
Yeah, so I went to Quinnipiac University for my doctorate in physical therapy. I became interested in the profession as a young high school athlete. I was a wrestler for all 4 years and into college. And in my junior year of high school, I suffered a rotator cuff tear and I had to undergo rotator cuff and labral repair. And then I had like 9 months of PT after that. And since going to that, and then with my mom being a personal trainer, I've always liked being physically active, exercising, and then seeing how physical therapists could use that exercise to help people with injuries and pain and all that sort of stuff. It just seemed to make sense for me. So I did some job shadowing after that, decided I want to pursue that career and went to school for it. Went to Quinnipiac for undergrad and grad school, and I've been out practicing ever since.
Nice, man. So that trend of experiencing an injury, sort of having a rehab process of your own to relate to, and then moving into a formal education in the subject matter, that's really cool. Did you spend a lot of time working with non-injured populations?
Most of my time was working with the injured populations. When I was doing my clinicals throughout school, it was mostly in outpatient orthopedic clinics, kind of like the ones I've been working at since graduating. So in those situations, you would typically see middle-aged to elderly populations. A lot of them would still be physically active, and that's where they were getting a lot of their overuse injuries. And you would see a lot of post-op patients as well. So the majority of the people that I've worked with have been active and exercising and all that sort of stuff. And that's how they end up with me, is often they'll overdo it or have some sort of acute injury and then have to come to see me in PT.
So I know when we were talking in the intro and then the three of us talking about what we're going to do on this podcast, we mentioned a spectrum ranging from rehab to performance. And so is that a belief that you have always held when you got into physical therapy? You knew they were on the same spectrum, or is that something you've come to realize over time?
Yeah, I mean, with my background with training just from a sporting standpoint and from weightlifting since I was a young teenager, I've always seen training and rehab sort of on the same spectrum. A lot of people, especially if they don't have like a sport specific or weightlifting background, they see them more as two separate entities that you're either doing rehab or you're doing sport specific training or weightlifting or performance training. And they don't see a lot of similarities between the two. But in my opinion, they're both on that same spectrum, but they're just on differing ends.
So when people come to you and they might be experiencing some pain and they're looking to get back to activities that they like, I think a very common sentiment that I hear on the strength and conditioning side of things is just that people expect a quick fix. They expect here, just give me these exercises to do for like 3 weeks and I'll be better and I don't ever have to do something again. Is that a common belief that you'll hear in your practice, or do you typically try and cut that off and explain to them that this is a long-term growth process?
Yeah, I mean, most people in general have that kind of quick fix mentality. We all want stuff to come to us quickly and with as little work usually as possible. But just like most things in life, that's not usually the case with getting out of pain or dealing with an injury. The vast majority of injuries that I see are non-traumatic injuries. So they don't have one specific mechanism of injury where, like at this instant, that person got injured. A lot of people I've worked with are weightlifters, powerlifters, CrossFit athletes. And with most of them, what kind of leads them to having to come to see me is just mismanagement of workloads. And this is more of a process that goes on for a period of time until that person's body or tissues or whatever you want to call it stops being able to handle that workload. And because it is this longer sort of drawn out process that results in them having these various injuries or pain states, it's very similar for how you have to deal with it. You have to do a lot of education on the fact that this won't be necessarily a quick fix. It is a process that has ups and downs, and it's really about finding the factors that you need to modify in their lifestyle and in their training, and kind of working with them through that process as their pain and injury start to calm down and heal over time.
So Ryan, you mentioned something there about kind of education and having to educate your clients on certain aspects of what you're doing. How much do you find is part of what you do education versus actual treatments and exercise and hands-on kind of things?
Yeah, so I mean, a lot of what I do really is educating the people that I work with about what is going on, what might not be going on, what they should be doing, what they should be avoiding, stuff like that. There's a lot of information out there either on the internet or by asking friends or family members, and people have been often given these tissue-specific or movement-specific diagnoses by providers that they've seen before me. And some of the information is really good and some of it's really bad and potentially harmful. So a lot of the education that I provide is centered around helping to reduce some of those maladaptive beliefs that these people have, addressing some of the narratives that they've been given that might not be exactly accurate, and then trying to reframe what we're doing in PT to their daily life and what they want to do from a functional standpoint. So a lot of people, if you just kind of keep PT or rehab in the frame of these are just rehab exercises that we're doing, and you don't draw the bridge between what you're doing there and how they're going to return to their full function, a lot of them have a disconnect and they end up not being as consistent or not putting an effort into it, and they get worse outcomes from that. So education is a huge part of what I do with everybody, no matter if they're a young athlete who's in the midst of training for a weightlifting competition, or if they're an elderly person just dealing with some more chronic type of pain.
So at the simplest level, what you were just saying is that if you can draw comparisons between what they currently are experiencing and what they need to do with an outcome in the future, will they be able to participate in an activity that's maybe important to them? That's what you're saying and part of your education process?
Yeah, absolutely. There's this saying that people don't come to see us because they're in pain. They come to see us because that pain is limiting them from doing something that they want to do or need to do. So if you're just talk about the pain that you're treating and all that sort of stuff and just focusing on that pain and not focusing on that person's goals, priorities, activities that they want or need to do, then you're just not going to get as good outcomes as you could or should be getting.
And so when you're focusing on something in order to create this outcome that your patient wants, are there any physical traits that are going to be more important than others? I guess I shouldn't create a hierarchy, but are there just physical traits that you think are really important for somebody to focus on when they're looking at maybe a rehab setting or a rehab protocol?
Yeah, absolutely. A lot of people, just because of kind of societal standards, they place an emphasis on things like flexibility and strength. And these priorities will differ person to person. A more elderly, less active person is going to have different physical priorities than a younger, more competitive athlete or a younger, more competitive person in general. So you really have to find out what that person prioritizes for them. Maybe it's being able to bend down to tie their shoes without discomfort, or pick up their grandkids, or it might be deadlifting 500 pounds. And all those things vary greatly person to person, and being able to really hone in and find what that person's prioritizing is one of the most important things, in my opinion, especially on that first visit when you're just meeting that person.
Along those same lines, I know as a strength and conditioning coach or a personal trainer, one of the biggest conflicts that we're possibly dealing with in the beginning is somebody telling me or telling us that they don't care how much they lift, they don't care if they build muscle. Some even say they don't want to build muscle. And I think they don't understand the implications of what getting stronger and building muscle actually entails, or what it will do for their lifestyle. And so are those traits as important in a rehab setting as they are in a strength and conditioning setting? And if they are, what are some examples of maybe a clinical diagnosis that would be improved with those two traits being moved forward?
Yeah, in my mind, I absolutely do think that those qualities are pretty important, either from a rehab perspective or just an all-around health and quality of life perspective. Two specific examples that I can think of off the top of my head are having to do with knee osteoarthritis and after somebody undergoes an ACL repair. So there's a lot of research for both of these conditions showing that quad strength and size, cross-sectional area, is an important factor, an important prognostic indicator for how well these people are going to do. So if you can build up a person's quad strength, whether they have knee OA or if they're just out of an ACL repair, those people are going to do better. Multiple studies have looked at ACL repairs and how well those patients do post-operatively. And the single biggest factor that they find that leads to poor outcomes is continued quad atrophy and weakness. And they found that people, even those who undergo physical therapy, can have deficits in those areas for 2 years or more. So in my mind, if you're going to properly rehab that person, especially if they do have more active goals, you really need to focus on those traits because building up hypertrophy builds or increases the potential that that person has for strength development. It's not necessarily a one-to-one ratio, but the larger muscle is, the more potential force it can produce. So putting an emphasis on both of those will lead to better outcomes. And just from an overall quality of life perspective, there's been many studies looking at strength training, improving strength and building muscle as being all things that lead to just a better quality of life, even for the elderly.
So if these two physical traits are so important, is there a difference in the way that we develop it, whether we're in a rehab setting or we're in a gym?
Not really. I mean, the physiologic processes and adaptations that you need to develop those two things is just similar across no matter who you are. So you need to challenge the muscular system potently enough to develop those traits. And that just doesn't change whether you're injured or non-injured, not dealing with pain.
So you just hit on one of the big principles without necessarily stating it specifically. So if we're looking at the principles of like our acute program variables and the principles of resistance training, could you maybe just define them a little bit for us and what we're going to be really paying attention to when it comes to rehab? Because I know you did touch on this a little bit earlier with modifying some of their training protocols, whether it's volume or intensity. So if you could just give us a quick rundown of the principles that you're really considering when you're talking to somebody in a physical therapy setting, and that way we can sort of refer back to them from a strength and conditioning setting.
Yeah, so when we're trying to drive hypertrophy and strength and all that stuff, we need to look at the intensity of the exercise, so how much weight or effort that person's putting into that exercise, the volume or how many sets, reps they're doing, and we need to look at the variables that will allow that person, if they're in a rehab setting, to do that within a tolerable level of discomfort. So the big discrepancy between rehab and just training is the level with which we can apply these various principles. People who aren't injured or who aren't in pain can obviously handle higher levels of intensity, higher volumes, whereas people who are dealing with injuries or pain can't handle quite as much. So we need to find ways to modify or adapt the training to still drive those physiologic adaptations that we want while respecting the fact that person is dealing with pain or an injury.
So you're kind of trying to find an entry point with wherever that person is in front of you, and depending on how they come into you and what their injury is, that starting point might be in a very regressed state or might be in a progressed state where you're seeing maybe a high-level athlete who's injured who can probably handle more volume and intensity than your average Joe who's not injured. So that kind of means that you have to be familiar with not only how to regress things for people that are injured, but progress training in a logical and progressive manner. So how do you go about kind of being able to handle that whole spectrum?
Well, the most important thing that I find with that is really doing a good job of talking to that person, finding out what their training history is like, what sorts of exercise they've done in the past, and what they've been adapted to before this injury or pain that they're experiencing. and then using that to try to find what you think is a reasonable entry to exercise. So if somebody's a younger athlete, and taking from that ACL repair example, if they've undergone ACL repair and they're a little bit out from the surgery, if we're going to start them squatting again, I might start that person with a little bit heavier loaded goblet squat or front squat, something like that, versus if somebody's older or less trained, just doesn't have the experience with lifting, I might have them do some TRX supported squats to a box. So it's about finding the right amount of stimulus for that individual person and then progressing from there. It's not something that's a perfect science. There will be some trial and error with each person, but you just have to try something out, see how that person responds, and then modify to give them the best care that you can.
Yeah, it sounds kind of a lot like what we do as strength coaches when someone comes in and we have to assess where they currently are and find a good entry point for them in training. I'll kick it to Ryan and see kind of what you have to say about that and how that compares to what they kind of do in physical therapy versus what we do in our assessment process, and how there's a lot of similarities there.
Yeah, I think the interaction between physical therapists and strength coaches is really cool, because at any one point the person in front of us exists on that like rehab to performance spectrum, and they can be moving in either direction at any time, and we're largely responsible for the direction that they move. There are going to be a lot of factors that are out of our control when it comes to acute injuries, but when it comes to chronic long-term injuries, we really sort of have the reins on that. And so being really careful with what we ask these people to do goes a long way, because at the end of the day, they trust us to not impede their lifestyle. And if we get over ambitious and maybe put this person on a program that their body is not prepared for, we run the risk of reducing their quality of life for a significant period of time. And so when somebody comes in and we need to figure out what kind of squat is going to be ideal for this person, what kind of deadlift is going to be ideal for this person, what kind of pressing movement is going to be ideal, we need to be just aware of a lot of different factors, from body composition, previous exercise history, previous injury history. And so that's just scratching the surface at some of the factors that both parties need to consider. And so having a concrete process to go through where we can safely challenge everybody that comes in front of us and then progress them forward over time is critical. And so that's sort of where I see the interlap, or the overlap between that rehab to performance spectrum, because like I had said, at any one time, they could be moving in either forwards or backwards. And so one of my biggest concerns as a strength coach is knowing my limits and not overstepping my bounds. And it's something that I ask nearly every physical therapist that I respect and talk to, where they see my role ending and their role beginning. So I'd like to just throw that question to you, Ryan, and ask you, where do you see that line being where a strength coach should say, okay, it's time for somebody in a different realm of this spectrum to take over?
Yeah, I mean, that can be a tough call for a lot of people. Typically, when I talk with strength coaches or personal trainers or other people who are working with the population, they're questioning whether or not they should send them out to a medical provider. I usually recommend that if they're working with somebody who has an injury or has pain and it's not gotten better over the course of several weeks, usually 4 to 6 weeks, then at that time you probably want to refer them out to either a medical doctor, physical therapist, just in order to have them be evaluated, make sure that there's not any medically emergent scenarios like a fracture, tumor, or anything crazy like that myself shouldn't be treating, but won't just get better with just training modifications and changing your activity. The way that I kind of treat people is pretty similar to how strength coaches work with their own clients. And that's, I largely use a hands-off approach. And I really try to get that person to build up their own self-reliance. And I use a lot of exercise to not only build that self-reliance, but also to cause the physical changes that we're looking for, whether it's endurance, hypertrophy, strength, that sort of thing. So if there's no good progress with a person's pain in that 4 to 6 week period, that's really when you should probably think about referring them out to somebody who could just evaluate them and rule out that scary type of stuff.
Okay. And so let's say we reach this point with somebody where they've been experiencing pain for, let's say, 4 weeks, and we need to toss it over to a physical therapist for the time being. What would be some of the language that you would use, or how would you approach that subject with somebody who might be a little bit on edge or a little bit nervous because they have had a reduction in what they've been able to do?
Yeah, so usually what most people do is when they start to have pain like that, or if it's been going on for a little while, they're going to do some Google searching. They're going to talk to friends and family. And like I said before, they might come across a lot of less than accurate information. They might see a lot of information about rotator cuff tears, impingement, all these really scary structural sounding stuff. And one of my main focuses is just to kind of go over what some of that stuff means and how a lot of those pathologic things like rotator cuff tears, impingement, bursitis is pretty common in the population of people who are pain-free and don't have any injuries, and that they shouldn't necessarily be worrying about what exact tissue or what is wrong in the shoulder, and they should be more focusing on this has been a little bit of a step back in the process of them training and weightlifting, and they just need to take it from there and try to work forward with a combined effort from physical therapist, MD, coach, anything like that.
And I just want to highlight, because that's one of my favorite topics that you just brought up, is that because there might be a structural abnormality does not mean that somebody is necessarily going to be experiencing pain. And so my favorite example of that is just Major League Baseball players and rotator cuff tears. And so with the majority of Major League Baseball players being asymptomatic but having rotator cuff tears, we can't simply reduce pain to a structural occurrence. That's accurate, correct?
Yeah, absolutely. Pain is a very complex experience that people have, and it's been very poorly linked to some of these structural things, especially when that pain has been more drawn out. If it lasts a longer period of time, it's been found to be a lot less closely correlated with true like tissue issues, as we would call them.
And I know as I scroll through Instagram, that's almost all that I see is these Instagram accounts saying, oh, if you have pain here, it's because this muscle's weak, so do this exercise and you'll be good.
Yeah, I wish it were as simple as that. Unfortunately, it's a lot more complex, and there's a lot more sort of things in a person's life that can contribute to their pain experience or injury that they're having.
Well, I think a lot of people have a lot of trouble wrapping their head around that idea that there can be damage and not pain, and that there can be pain and no damage. Do you think you could go over kind of the basic process of the sensation of pain and what we do, how our body kind of has that pain process? I think some people have this idea that, our tissues get damaged and it sends like pain up to our brain and that's our pain. But I think it's a little more complicated than that. If you could go into a little about that.
Yeah, absolutely. So pain is not something that's sensed by our body. Like we don't get a cut and then those nerves in our arm or wherever we had that injury send the pain signal up to the brain, and then the brain realizes, hey, we have pain. Pain is actually an experience that our brain produces in response to a real or perceived threat. And that's really one of the most important things when we're talking about pain is that threat can be a true trauma that you've experienced, or it can be something that your brain thinks you have or will have. A good example that I like to use for that is showing people that they can have true tissue trauma without having pain, and vice versa. So pretty much everybody's experienced a scenario where you're going to the shower, you look down at your leg or arm or something like that, and you notice a bruise that you didn't ever remember getting. Clearly in that scenario, you had enough tissue trauma to cause some bruising and bleeding underneath the skin, but you never had a painful experience with it because your brain did not classify that as something that was a threat to your body at that time. And the opposite can be true. You can have true, real, intense pain without having any structural injury. And the biggest example of that is probably people have amputations and have phantom limb pain. So that person literally feels that pain in that missing limb, but they don't have any tissue there to cause that pain response.
So I think one of the coolest stories I heard was about some guy who stepped on a nail while he was working and was in extreme pain and had to get an ambulance, and they took him to the hospital and they took his shoe off, and the nail actually went in between his toes and didn't penetrate his skin at all. And he still had a very painful experience, and his pain was very real, but there was no actual tissue damage. And something important you said there was about perceived threat and how just how our bodies can sometimes perceive something as threatening that might not actually be threatening. And I think a lot of that has to do with the words we use. And I think that's another big similarity between physical therapy and strength and conditioning, and a reason both fields should be familiar with one another is because the words we use have a large impact on people's experience, whether it's from a training standpoint or from a pain standpoint. Could you go into a little bit about that?
Yeah, so people have done a lot of research over the years looking at the effects of language, especially from medical providers. And there is real documented effects that come from the language that we use when interacting with the people that we're treating. Those effects can be either good or bad depending on the type of language that you're using. So when somebody is being seen for some back pain, if they're told that they have severe disc degeneration or severe structural changes like that, the very language that we're using in saying that things are degenerated, broken down, you have the back of an 80-year-old, things like that, that can heighten that person's pain experience. Versus if you use helpful language like saying how those changes might not necessarily be causing their pain, not saying things like you have the back of an 80-year-old, reassuring that person and kind of meeting them where they are, then in that case, the language that we're using can actually help that person cope with what they're experiencing. So we have to be very, very selective with the language that we use. And that's not something that a lot of people kind of prioritize when they're working with clients, patients, that sort of thing.
Well, I think the negative language that some healthcare providers choose to use, coupled with the overly reductionist mindset towards pain and tissue damage, they go hand in hand. And so when you have somebody who firmly believes that if there's pain, that means that there's damage, or that if they're doing something and it causes pain, they're doing permanent damage, couple that with a healthcare provider who might not be up to date or understand how nuanced the subject can get, and they merely just look at what would be considered deviations from sort of like the norm when it comes to imaging. That seems to me like it would be the perfect cocktail for somebody feeling helpless and lost, and like potentially that surgery is their only option.
Yeah, I mean, a lot of the people, I work a lot with people who have shoulder pain. And the number one most common diagnosis that those people are given is impingement syndrome. And that diagnosis itself has come under a lot of scrutiny in the past couple of years just due to research on that topic. But if somebody's told that the reason they're having pain is because every time they move their arm, their tendon is grinding against the bone in their shoulder, then in their minds, they think that nothing else besides removing that piece of bone is going to help solve their pain problem, when it's been shown that exercise is just as effective for rotator cuff related pain, or what they would typically call impingement. And that's just an unfortunate scenario.
Would you be willing to just define what impingement is and what it might look like in different parts of your body?
Yeah, so when we're talking about shoulder impingement, the typical kind of definition of that is there is a bony arch in your shoulder called the acromion process, and underneath that arch is a lot of soft tissue in your shoulder. So you have some bursa, some tendons of the rotator cuff, the tendon of the long head of your biceps, and it used to be thought that a lot of front-sided shoulder pain was the result of abnormal rubbing of those soft tissues between the acromion and the head of the humerus. And what they've recently found is that that amount of rubbing is completely normal. Every time we lift our arms over our head, we get rubbing or compression of those soft tissues between those two bones. And it's something that's normal and shouldn't be feared. It's pretty much unavoidable. And that impingement occurs as low as 30 degrees of shoulder flexion, which is pretty darn low. You don't have to lift your arm all the way over your head to have some of that compression between those bony surfaces.
And so this old mindset of all shoulder pain is impingement, we've kind of gravitated, or we've moved past that and left that in the past. And we have a better understanding of what to do now.
Mm-hmm. Absolutely.
Okay. So let's take that shoulder example, because it's very common, and you say yourself that you work with a lot of people with shoulder pain. And so if somebody is experiencing pain in a region of their body, would you recommend that they shut down all of their training and completely rest until that area of their body is feeling better?
No, absolutely not. Complete rest is one of the things I most kind of vehemently advise against. What you really need to focus on is modification or reduction in volume or intensity of those exercises that do really flare you up. So in most scenarios for shoulder pain for the weightlifting population, bench press and overhead press are the two exercises that are most commonly going to flare people up. So I would never recommend that people just completely stop overhead pressing or bench pressing, but we can manipulate tempo, load, volume, variation of that exercise in order to find an entry point into that movement that they can do and slowly progress back towards their normal amount of training.
Now, if you were to be with somebody, I'm going to throw you on the spot here, and let's say, I'm your client, or your patient, I should say, and, it's just not as fun to not be able to train at 100%, and I really just want to dog it for the next few weeks. How would you explain to them the importance of staying moving and continuing to train even if they're not quite at 100%?
Yeah, so when people are into exercise or into lifting, they're usually always seeking to improve upon one facet of fitness or another, whether that's muscular size, muscular endurance, strength, that sort of thing. So what I tell people is if they just completely take off 6 weeks of training and don't do any upper body pressing, then they might have some atrophy of those muscles that they've been kind of trying to build up. Their strength and endurance is going to decrease, and they're going to lose a lot of the adaptations that they've worked so hard for in the past, versus where if they just modify their training, even though they might not be able to max out every week like they've been wanting to, they're still going to keep a lot of those adaptations that they've developed over their training career.
Do you think maintaining that mindset towards their training, even if they're not at 100%, carries over into other aspects of their life or future injuries?
Yeah, absolutely. I mean, we as coaches and clinicians know that training and rehab is a process that has ups and downs. You're not going to continuously just progressively get better day by day, week by week. You will have peaks and valleys, and knowing how to respond to those increases or decreases in performance is an important part for people to learn. Because if people expect that they're just going to continuously get in less pain, get bigger and stronger without any sort of fluctuations in the process, they're setting themselves up for failure, in my opinion.
Yeah, I mean, if we just added 5 pounds every week, we'd all be benching 1,000 pounds in no time, right? That'd be the dream. Do you find that people are coming to you when they're in pain and they're afraid of working out? Is that ever something that you have to deal with?
Yeah, a lot of people develop fear of the movement or exercise that they've been experiencing pain with. And that's something it can sort of be thought of as an adaptation to avoid further irritation of that painful or injured area. But while it can be helpful in the short term for having them shy away from that amount of loading or that movement, in the long term, it can really affect them from a psychological standpoint. So if somebody hurt their backs deadlifting, then they kind of continuously spin their wheels, and every time they try to deadlift, they have this really bad association with deadlifting to pain. It's kind of like when people get sick from a certain type of food. They have a bad reaction to that food, they get sick, and then the next time they even smell that food, they feel like they're going to get sick again. And it can be pretty similar with actual exercise itself.
And then you kind of see this kind of carry over to their regular life, and they start to become fearful to do activities they love. And, they might have hurt their back deadlifting, and now they're scared to pick up, their kid off the floor or something that is a little more valuable to them. So what's your process of trying to get someone over that fear and back to doing those movements that are kind of necessary in life that you can't really just avoid?
Yeah, I mean, I try to really use like a graded exposure type of treatment. So if they develop some pain while deadlifting, then maybe initially I'll shy away from actual deadlifting straight off the floor, and I'll kind of implement that movement pattern in a way that is either less frightening or non-threatening for that person. So maybe initially I'll have them work from picking a kettlebell up from a chair, and then eventually I'll lower the height of the object and have them pick up a kettlebell from a stool. And then I'll transition them to doing block pulls and then eventually full pulling off the floor. So it's finding a way to still have them work that same movement variation with a lot less of that threat, and then gradually exposing them to more and more stress and getting them back to the full lift itself.
It almost seems painfully simple, right? It's like if there's somebody in front of us who wants to be able to perform a task, but at this current moment in time, that task is a little bit too difficult or strenuous, just make it a little bit easier, and over time make it harder and harder until they're able to do it again, right? Like, it seems simple. And how many thousands of dollars in student debt do we have between the three of us? I'm kidding.
Yeah.
But it's hard to do, right? And the devil's in the details. And so do you think that the longer you've been in the field, you started to pay attention to some details that you may have overlooked in the beginning?
Yeah, absolutely. When I was first out of school, I was kind of the mindset that there are more specific rehab exercises or techniques that you should do. I was definitely more focused on hands-on treatment, manual therapy, and I wasn't really as big of an advocate about talking about pain, talking about expectations, talking about that person's specific goals, and really kind of devoting everything to what that person wants to achieve. And then over the course of my career, I've shifted my thought process and my treatment style to make it less hands-on from my perspective, more of that person actually doing tasks to get them better and more confident in themselves, and just making this more of a conversation and me guiding them than anything else.
What you brought up there is one of the pillars of what Resilient Training Lab is. And so that was self-efficacy, the feeling of yourself being in control, and you're creating your own outcome when it comes to your rehab process or your training in the gym or any other area of life, right? So are there specific ways that you go about trying to create this sense of them being in control and in charge? Is it just through education and talking to them? Do you show them? Do you have a specific protocol or part of your process that you think relates a lot to that?
Yeah, absolutely. I mean, a lot of it is just education from my perspective. When most people come to see healthcare providers, they're in the mindset of, I'm coming to you so that you can fix me. And I tell these people, and I converse with these people and really try to drive home the point that it's not I'm fixing you, it's I'm giving you the tools so that you can kind of move things along by yourself, but with me guiding you. So it's more of a team effort where I'm advising or guiding, and that person's putting in the work to do what they need to do to get better. It's just one kind of real long conversation throughout the time that I'm treating that person. The last thing that I want is for people to come to see me because of pain or injury, and for them to feel like they absolutely need me to get them better. I want people to be as self-reliant as they possibly can.
And I know as coaches at Resilient Training Lab, we try and embody the same process or the same philosophy, where we want our clients to be comfortable enough to go into a gym and train without us if they need to. We want them to be comfortable executing and being confident in what they're going to do. And the reason for that is we see it go a long way when it comes to their mental health and their self-esteem. And again, that feeling of self-efficacy. And so do you feel that, or do you notice in your clinic when a lot of people are coming to you that what they're currently unable to do has a big psychological effect on them?
Yeah, it does. Especially for us as people who like to train and like to lift, that part of our lives becomes a big part of our identity. And we kind of see ourselves as lifters, as coaches, as athletes, that sort of thing. So if somebody's dealing with a lot of pain or injury and it's really affecting their ability to train, then that's affecting a big part of their identity. And that comes with a lot of issues in and of itself.
What would you tell them to do, or how do you handle that when they come to you, right? Because if somebody's, let's say that they're an athlete and they can't play their sport, how do you sort of talk them off the ledge?
Yeah, so with athletics and with non-barbell sports too, there's a lot of facets that go into being an athlete and into training. Maybe if somebody is a football player and they're dealing with an ankle fracture and they can't play football, they can still train in some manner, and whether it's just upper body strength power work, unilateral lower body work, and they can still work towards being that same athlete that they were, but just in a modified manner. And finding ways for people to do that and experience that themselves is really important for that process.
And I think it would help them maintain a little bit of a routine as well, right? Instead of their maybe sport-specific practice, they have their rehab or their training at that point in their day. Now, again, going back to sort of the interlap between strength and conditioning and physical therapy, you started working more as a strength coach with the Resilient Training Lab and doing more programs for people who aren't necessarily limited. Do you see any difference between the two? Do you get to do a little bit crazier stuff with the people who aren't injured?
Yeah, I mean, for the people who aren't dealing with pain or injury, you can usually do some more volume, higher intensity, stuff like that. But besides that, it's pretty similar. You just need to find the appropriate amount of stress to drive the adaptations that you're looking for that person, and then monitor what you've had that person do and adjust as needed.
Would you say that your mindset is unique in your field, right? Because I know, and what I brought up earlier, that a lot of what I see in the physical therapy Instagram land is a lot of, again, overly reductionist mindsets. What do you think has really created this trend in physical therapy to view it on the same spectrum as strength and conditioning? And how do we sort of move past this idea that there are perfect rehab exercises versus performance exercises?
Yeah, I mean, I think that more and more, especially lately, there's been more younger PTs who are athletes themselves, do a lot of lifting themselves, and they come from this more athletic background, and they've used their own experiences in that avenue to help shape them as PTs and to kind of veer them away from that typical sort of thought process of this is rehab, it's not performance training or sport training or anything like that. And there are specific sort of isolation, banded, whatever exercises that you need to do. So luckily, we're seeing a lot better understanding of general strength and conditioning principles in some of these newer grad PTs. And a lot of them are now trying to use their voice and use social media platforms to hopefully cause some changes in the professional level. If we could really move towards focusing on self-efficacy, resiliency, not shying people away from strength training and heavy lifting as a profession, I think we'd be in a lot better spot.
So that's one of the biggest obstacles that Paul and I talk about when we're in the gym is removing barriers to working out and training in general, and maybe trying to dispel a lot of myths that create negative feelings towards lifting weights. Something that I see a lot of in the gym is people who are very hell-bent on doing high-intensity interval workouts or very demanding body weight exercises that require a very high degree of strength relative to body weight. And I'm thinking specifically of somebody who I've worked with in the past, and this person was experiencing knee pain. And when I asked her when she had been to physical therapy if she had done any squatting, her physical therapist told her no, that she wasn't allowed to squat, and they didn't do any in the weeks that she had been there. But she was allowed to do or she was allowed to participate in her sport, which required a lot of jumping and landing from elevated surfaces. So I was hoping you could just kind of touch on your thoughts on the fear of movements or the fear of exercise, and then looking at the demands that we have to undergo, or the forces that we have to undergo doing a lot of these sort of glorified exercises or body weight movements.
Yeah, I mean, that can be a really tough situation to have to deal with, whether that's from a PT perspective or like a coaching perspective. I've dealt with situations in the past where I've been treating somebody who had a total knee replacement, and they've been told from their provider that they could never squat again. So when I come across situations like that, the strategy that I usually try to utilize is I like to try to ask that person a lot of questions and try to lead them down a certain kind of line of thinking. So if I've come into contact with somebody who's been told that they can't squat and they're doing really high demand tasks like Ninja Warrior type stuff, then I will ask that person why they feel like they can't do these tasks like squatting, what they feel like the differences in forces that our joints handle between things like squatting versus jumping, landing from high distances or high heights. And then I'll try to just kind of reason with that person and lead them kind of to try to question what they've possibly been told before. If you can get that person to start kind of thinking a little bit more freely and questioning some of the advice that they've been given in the past, you're going to get a lot farther than just like saying, no, that advice was bad. It isn't really like that. You can just squat, you'll be fine. Because when people have been told stuff like that by people that they trust, going against those beliefs can be a very challenging situation.
So what would it kind of look like in, well, let's give like a specific example of, someone who had hurt their back and they've been told not to deadlift ever again. What would a kind of more specific rundown of that situation look like, or something you would do to try and talk to them about the necessity of being able to pick things up and change their mindset around that?
Yeah, so first I would just kind of go into my whole belief that deadlifting is a good exercise. It's not inherently dangerous. It doesn't carry any higher injury risk potential than other exercises do. And then I would go from there and then kind of just talk with that person and ask what they feel comfortable starting with. If they feel comfortable doing some just active hip hinging drills without any external load, that person I will start there. We'll continue with that drill until they feel safe and they feel like they're not going to hurt themselves. And then I'll try to progress it a little bit harder. So maybe instead of just hip hinging with a dowel, they'll do it with a band around their feet that they're holding on to. So they're getting a little bit of load at the top of the movement and none in the bottom where they might feel a little bit more threatened. After we work on that, we'll go to pulling some light loads from pretty high heights so they're not moving very far, and then just gradually working them down to the floor until eventually they're lifting barbells from the floor if that's their end goal.
So, Ryan, this is kind of something we see a lot when people come to us, is they have certain preconceived notions, or they have these ideas about certain movements and lifting, and we kind of have to show them what they're really capable of. They kind of have these ideas of what they're able to do, and part of our job is to show them, that they're more resilient and capable than they really think. So there's a lot of parallels there. What are some examples we see where kind of our language is impacting people's pain experience, or maybe their lack of pain experience, or avoiding that pain experience?
Yeah, so I think at the easiest, or at the ground level, my go-to with language when it comes to, let's just say, deadlift is I start by trying to point out all the times throughout the day where they're deadlifting, and they don't even realize it. So whether that's picking something like a laundry basket or like a heavy bag up off the ground, picking a kid up off the ground, trying to create something that has emotion attached to it and something that they feel very confident that they know that they can do, right? Like picking up their kid, they do it every day, all day. And then from there, reinforcing and trying to create a sense of confidence in the position. And so highlighting a lot of their successes in the gym is one thing that I try and do, and it's a small way that my language and the words that I use can, again, reinforce the experience of the client and hopefully increase their long-term adherence. And so I think I mentioned this in another episode of the podcast, but pointing out one day I pointed out that one of our members was just casually walking around with over 100 pounds in her hands, and she wasn't thinking twice about it, but I thought it was really cool that she just made it look so easy. And so I would say that that's the easiest way where my language or the language that we use as coaches can reinforce the client's experience. And then what you mentioned about pain, it gets a little bit trickier. And so what I try and do is I try and show them that they can handle positions by changing the exercise. And so I know earlier I had said, the kind of the devil's in the details when it comes to rehab. And it's the same thing with strength and conditioning. And so as long as we can find some exercise where they're in a similar position and they're tolerating it well, just constantly reinforcing their little victories set by set or training session after training session, so that they again start to feel that sense of self-efficacy, that sense of confidence and ownership over what they're doing. And I think that's sort of the biggest way that we try and use our words to create positive outcomes for the clients. Would you agree, or is there something different that you do?
Yeah, no, I agree completely, because what I was thinking about was how, the words we use are kind of laying the foundation for Ryan Van and his physical therapy process, and how us as strength coaches, we have a lot of power of the mindset that our athletes enter the rehab process and where they are when they go to physical therapy. And if we're, as strength coaches, using language that makes people fearful, they're going to be more likely to experience an injury. So we need to be aware of the nocebo and placebo effects of language and how they affect our clients, so that if they get hurt and when they get hurt, that rehab process is much smoother, because they're already aware of how resilient their body is and how adaptable they are and how they will overcome this, because they've overcome so many hard things in the gym already.
Yeah, I mean, with what you just said right there, it's huge. You said if they get hurt and then when they get hurt, right? I think it's also important to explain to them that what they're feeling is normal, and not to downplay it, because their pain and what they're feeling is very real. But some of the statistics surrounding these painful events can be almost common, right? If at any point in time 1 out of 7 people is experiencing some level of back pain, they start to think of it as normal, and they don't necessarily freak out every time they feel a little twinge. And so how do you approach that subject with somebody that you're working with, Paul, where somebody who might not necessarily understand in the beginning that sometimes exercises can be a little bit painful, and that's okay?
Yeah, I think that's huge. And being able to understand the pain process and explain it to the clients and be able to kind of understand the underlyings and the things that are happening and give the client a greater idea of what's actually going on can go a long way to empowering them to be able to deal with those little aches and pains that otherwise might have became big aches and pains if they started to catastrophize and started to make a big deal about those things. So it's very helpful as strength coaches to be aware of how people experience pain and why they experience pain, and be able to have that conversation with clients. And then it really all comes back to workload management, and that is the same regardless of whether you're in the rehab process or training to be an Olympian. You have to assess where the client currently is and apply a stress that they can handle at that time and progressively overload that stress so they become better than they were the day before. Another big thing that I think Ryan Van talked about that we have a large impact in is the lifestyle factors that play a role in pain, because they play a role in training too. And Ryan Van mentioned a few times that having this strictly tissue view of pain can sometimes be damaging because it's much more multifactorial than that. And some of those factors that play a role in that pain process are things that we really pay attention to in the training process. So Ryan K, can you go into some of those things that we look at in the training process that, will benefit people again when and if they get hurt?
Yeah, so when we're looking at a new client in the gym and introducing strength training as a new part of the equation, I like to have a conversation with them from the beginning about how we have a certain tolerance or a certain capacity for stress in our daily life and our weekly and monthly life, and how we can't always just continuously add stressors without there being negative consequences. And so I always explain to them that in order to recover from our stressors, we need to be sleeping. We need to be making sure that we're eating and participating in activities that help reduce the overall feelings of stress that we have. So if somebody likes reading or going for a walk or playing with their dog or whatever it is, after they have a very stressful day, that those activities have a lot of value. And the better we can get at managing our stress, again, through those different avenues, the better our training program can be, or the more stressful our training program can be. And so if we can really just highlight how important it is to nail down these different stress management techniques, they'll get a lot more out of their time in the gym because we're going to be able to push them harder while they're with us.
Yeah, and we actually just did a recovery seminar, plug on our YouTube, go watch it. And we talked a lot about how recovery is really driven by a lot of the passive things we can do, such as stress and sleep, and stress management, sleep, and nutrition. And Ryan Van, how would you kind of say, or does the recovery process differ from someone in rehab versus someone training, or do those same factors drive recovery?
No, I mean, overall, it's pretty similar. The same factors that drive recovery, such as getting adequate sleep, having adequate nutrition, hydration, and really managing just overall stress plays a huge role in recovery. And that's because all those other stressors will affect people's pain experience so much. A lot of people who experience chronic pain, whether it's shoulder pain, back pain, hip pain, anything like that, when they go through periods of higher stress in their daily life, whether it's tough times at work, they're having arguments with the spouse, any of those other mental, psychological, emotional stressors, often they'll have flare-ups in their pain. And even though people might not realize that that might be why they're having those flare-ups, it absolutely contributes to what they're experiencing. So I talk a lot about the same type of stuff with the people that I treat. You really want to try to address those stressors as you can and make sure that you're getting enough sleep, doing activities that you enjoy, finding some time to relax and all that sort of stuff in order to drive your recovery in the gym and from whatever pain or injury you're experiencing.
Yeah, I think one of my favorite sort of examples of what we're talking about here is, Mike Stoke Boogie, plug for him, is he's got shirts that say some days off instead of no days off, right? So it is important for us to take days off or time away in order to recover from what we're doing. And it'll ultimately allow us to push farther. And I think a lot of people hold themselves back because they don't take recovery serious enough.
So it sounds like we're kind of talking about a lot of the same things here from a rehab perspective, from a training perspective, and that there's really this continuum of rehab to training to performance, and where as strength coaches and as physical therapists, we need to be aware of both sides so that we can best serve the people in front of us. So Ryan, if you could kind of just give us some of your major overarching training philosophies.
Yeah, I think the two most important things that I think of is making the person's training as specific to their goals as you can. If you are training a powerlifter, you're not going to make them do crap ton of aerobic training and try to turn them into a marathon runner. You need to focus on what they want to focus on and improve upon with their training. And then really the biggest thing from both a performance and injury risk perspective is workload management. If you underdose that person's training, they're just not going to experience the physiologic adaptations that you're trying to drive. And if you really exceed that person's capacity and overdose their training, then they're likely to wind up in those injury or pain state categories.
All right. And then one last question. If you could go back in time and ask PT school Ryan, or tell PT school Ryan one thing, what would it be?
I honestly think the biggest thing that I would tell myself back then is to worry less about the actual techniques that you utilize to work with people, less of the hands-on manual therapy techniques, less of the specific rehab type exercises, and really learn how to connect well and communicate well with people. Those two skills are going to bring you a lot farther when treating and working with people than whatever you do with your hands or whatever exercise you use or anything like that. If you can't connect with that person, and if you can't communicate both evidence and your goals effectively, then the rehab or the performance training just is not going to work nearly as well.
And so speaking of connecting with people, how can people connect with you? Maybe give a rundown about your new endeavor. Yes, ill-timed as it may be. How can people get in contact with you?
Yeah, so you can find me on Instagram and Facebook as the Barbell Doc. I'm in the middle of opening up a physical therapy clinic inside of Revolution Fitness Clubs. Unfortunately, that was ill-timed with COVID-19, and as of right now, it's not open yet. But as soon as the gym is back up and running, the clinic will be up and running. I'll be working with you guys for coaching from here on out. And you can also reach me at ryan.van, VANN, at resilienttraininglab.com.
Awesome. And as always, Resilient Training Lab on Instagram. We have Paul_Resilient, Ryan_Resilient, www.resilienttraininglab.com. And if you are listening to this, we would love it if you leave a review for us so we can start to build some clout. Anything else?
Leave those only 5-star reviews, though.
Yeah.
If it's less than 5 stars, don't bother.
Just call us out in the gym or something. Just don't put it on the internet. All right. Thanks for listening, everybody. Ryan, thanks so much for your time.
Thanks for having me.
Thanks for coming on, Ryan.
All right. Until next time.